Good morning. My name is Aditya Nair, and my today's topic is stages of recovery in stroke and its management. So, what is stroke? Stroke is the sudden loss of neurological function when there is an interruption to blood flow to the brain. There are two types of stroke: hemorrhagic stroke and ischemic stroke. Stages of recovery. Stages of motor recovery following stroke. There are like 6 stages, and this was first initially described by Twitchell and Brunstrom. So first is stage one. Stage one, also known as stage of flaccid paralysis. That is, recovery from hemiplegia occurs in a stereotyped sequence of events that begins with a period of flaccidity immediately following the acute episode. No movement of the limbs can be elicited. As I say, this is the stage of flaccid paralysis, though there will be no movements initially in this phase. Stage 2. Stage 2 is when the particular flaccid paralysis is replaced by upper motor neuron signs like spasticity, hyperreflexia, obligatory synergies like mass synergies. Not only one, like so many synergies together, obligatory synergies we say. Stage 2, described as recovery begins, the basic limb synergies or some of their components may appear as associated reactions or minimal voluntary movement responses may be present. At this time, spasticity begins to develop. Stage 3 is when the particular movements, that is the voluntary movements or the voluntary control of the movement starts occurring in full range of motion, right? And spasticity has also further increased in this stage and may also become severe. Stage 4. So in this particular stage there will be out of synergy movements, that is out of like the particular pattern, out of that pattern the particular synergies are going to occur in this stage. It is described some movement combination that do not follow the path of the either synergy are mastered, first with difficulty, then with more ease, and spasticity is going to decline in this stage, is starting to decline. Stage 5. Stage 5 is the synergy has reduced, that is the dominance of the particular synergy has significantly reduced, and the spasticity also has reduced in this. Now stage 6. Stage 6 is the spasticity has disappeared. The particular person, the movements are almost normal. The synergy has also almost disappeared. Individual joint movements become possible and coordination approaches normal. From here on, the last recovery step, normal motor function is reduced, but this stage is not achieved by all. For the recovery process can plateau in any stage, that is it depends on the patient, that how they are doing, depends on the age, depends on the severity, as well as depends on the location of the lesion. Not everyone can achieve these stages, so sometimes the particular recovery just stays constant, that is can plateau at any stage. So next is we are moving on to the management. So first we have the medical, pharmacological as well as the neurological management. In case of medical management, we have to, when the first patient comes into the setup, we have to improve the cerebral perfusion by re-establishing oxygenation, also the circulation. Then they have to reduce the BP, that is the blood pressure, reduce the blood pressure back to normal. They have to maintain the cardiac output as well as prevent many complications like DVT, right, as well as aspiration, deucombitis, ulcer, pressure SARS, and so forth. So these are reduced by basic ankle pump movements. Aspiration can be actually reduced by using the suctioning so that the secretions can be removed in the early phases. Ulcers and everything can be prevented by any type of air bed or water bed can be used at this stage. Then drugs like thrombolytics, anticoagulants, antiplatelet therapy, antihypertensives, antispastics, etc. are used to treat stroke patients. Thrombolytics are usually for the clots formed. That is, we know that in case of ischemic stroke, there is obstruction caused due to the clots. So for that, thrombolytics can be used. Anticoagulants, same, not for clot formation, but to prevent clot formation, that is warfarin, heparin. These drugs are given. Antiplatelet therapy can also be given. Antihypertensives to reduce, to bring the blood pressure back to normal. Antispastics like diazepam can also be used to bring the tone back to somewhat of normal. The neurological interventions include mechanical thrombectomy as well as carotid enterectomy. Now we move on to the physiotherapy management. So in physiotherapy management, every patient has their own management. This is just the general one. So first we have taken for shoulder pain. Shoulder pain usually occurs in stroke patients, while like subluxation or dislocation has occurred in case of in case of stroke patient, because there are two types of effects, that is flaccid as well as the spastic cause is there. In case of flaccid cause, like flaccid at the time of flaccid paralysis, there is a time when the particular muscles have been paralyzed, around the area the proprioception has reduced. At that time, uh, subluxation or dislocation can occur, as well as in spastic cases due to increased muscle tone as well as the poor positioning of the limb, it can cause subluxation or dislocation of the shoulder, which leads to shoulder pain. So for that, patient education, that is, you have to educate the patient that even if you move the particular limb, if you have to instruct the caretakers, whenever they move the limb, they have to mobilize or stabilize the scapula while doing passive range of motion. Also, shoulder support orthosis can be given, or slings are given if subluxation has already occurred. As I said, positioning is very important, because even extreme external rotation can also lead to subluxation or dislocation. So second is for spasticity. As we know that the spasticity develops as the grade 2, the spasticity starts developing. And for spasticity, slow passive movements can be given, as well as sustained stretching. Stretching can reduce the tone by causing relaxation through autogenic inhibition. Then comes our braces. Braces is for keeping the particular joint in a lengthened position, so that you can prevent contractures and everything. As well as cold can be given. Cold will also cause relaxation, as well as it reduces the nerve conduction velocity, which it also reduces this motor spindle activity. And cold packs can be given for 20 to 30 minutes. Massage can also be given, as well as electrical stimulation can also be given to reduce the muscle tone. Then for sensory function deficits, we have two type of programs: sensory retraining programs and sensory stimulation programs. Sensory retraining programs is done by mirror therapy. Mirror therapy is that is while they are doing any type of exercises, or while they are doing any type of exercise, they can keep the mirror, so there is a type of biofeedback. They know whatever they're doing, at least they know how the hand is going, so they can just. Then we have repetitive sensory discrimination activities, like you have to use different textures like brushes, cotton. Okay, and this should be done bilaterally, so that they know what type of feeling, how it is felt. Then repetitive task practice, you have whatever textures or whatever exercises we are doing for the sensory function, it should be done repeatedly. Then only they may be able to re-educate themselves. As well as sensory stimulation programs, we have weight bearing. Weight bearing causes compression as well as approximation, which can also increase the which can also stimulate the sensory function. Thermal stimulation should be done with precaution, as there is some type of sensory deficit. So if it is too hot, they may not be able to know, and it can cause burns and everything. So it should be done with precaution. Intermittent pneumatic compression is for pressure. It is also for pressure sense. Electrical stimulation also should be done with precaution, because it also has the same effect. It can cause burns or something like that. So for gait and locomotion, we can use treadmills, that is robotorized treadmills, or treadmills wherein the person is attached with a harness above, so that they will not fall, and also there will be a support also present. Rhythmic auditory cueing, lower extremity strengthening. Yeah, lower extremity strengthening is very important, as well as management of spasticity is very important for gait as well as locomotion. Also, while gait training, the therapist should be standing by the side, because fall risk is very high. So standing by the side to support the patient if the patient falls. Then we have improve range of motion. Yeah, range of motion should be improved by passive range of motion exercises in the acute phase. Then moving to the active range of motion exercises with terminal stretch. That is, stretching should also be done so that the particular muscle is kept in lengthened position. As spasticity is present, then it can go into the shortened position. Positioning strategy should be implemented. That is, I say the particular joint should be kept in the lengthened position. Self range of motion activities can be taught to the patient, like polishing the table, which should be task specific, like ask the patient to wipe the table, so there will be range of motion, some type of movement at the hand. Then supine hands clasped together, that is, ask the patient when they are sleeping, just take the hands together at the back and ask the patient to let the elbows touch the plinth. Then coordination with team members, family members, caretakers, staff is very important, as therapist will only be there with patient for like an hour or so. So more than that, the family members are together, so they should also be taught how to teach the patient all these things. Then we have postural control and balance. In post-stroke patient, balance as well as postural control is very impaired. So balance training should be always task specific, like stair climbing, then sit to stand, in sitting only, to how to improve like sitting balance by functional reach outs. Training at task level begins by having the patient hold a position as well as or move in and out of the position, that is functional reach, as well as hold the position, that's standing. Standing with eyes closed for 1 minute, standing with eyes open with 1 minute, with narrow base of support, then with wide base of support, then narrow base of support. So these all are how the exercises which should be taught to the patient according to their needs, as well as safety should be ensured, because in acute phases they have high fall risk, as I say. The goals of the training should progressively increase the difficulty while ensuring symmetry, consistency, and maximum use of affected site. Supportive devices like harness, splints should also be used. Now comes strengthening. Strengthening also should be task specific. Muscle weakness is very common in stroke patient, leading to significant activity limitation. That is, the patient may not be able to climb the stairs, may not come in sit to stand position. So strengthening is very important in this case. Exercise modalities for strengthening includes free weights can be used, weight elastic bands can be used, that is TheraBands can be used, as well as machines can be used, but machines are usually used in the later phases. So in the starting, we can use free weights as well as the TheraBands, and these particular exercises should be task specific. Like that is, while stair climbing, that is stair climbing as well as descending and ascending stairs can be done with TheraBands. Particular resistance can be given, as well as progressive resistance strength training should be done in people in patients with a grade less than 3/5. Gravity minimized exercise using sling suspension, that is suspension exercises can be given, as well as aquatic exercises are very useful in these type of patients, and the fall risk also will be less, as well as the safety will be more in case of aquatic exercises. So these were the management strategies. There are more, but these are the all I have included, and the reference is from Physical Rehabilitation by Susan B. O'Sullivan and Physiotherapy in Neurological Conditions by Megha Sheet. So thank you.